Assalamu alaikum. Hope you're all doing well. So today we will discuss the second part of the interpartum care NICE guideline, and in that specific lecture, we will discuss the summary of the whole guidelines. That what are the important points that you will just quick go through in exam. So these are the important points you have to remember in exam point of view, and usually the interpartum care NICE guideline is very important, and if you crack these points, then it will be very easy for all of you. So in that case, we have already discussed in interpartum care NICE guideline that what observation we will do while during labor. Just a quick summary of all the things. So in observation in first stage of labor or in second stage of labor, so in low risk patient, we will do intermittent auscultation, but in high risk patient like those having meconium stain, like those hypertensive, diabetes, or you have suspecting APH, so in that case you will do continuous CTG. But if the low risk patient, remember this point that this is one of your SBA, that for example the scenario is given to you and there is no any such high risk point, so what you will do, you will do intermittent auscultation. So in first stage of labor, you have to do intermittent auscultation every 15 minutes, and in second stage of labor every 5 minutes. And the other thing is uterine contraction. In both, every 30 minutes you have to check the uterine contraction. And per vaginal examination, you have to check every 4 hours, and in second stage of labor every 1 hour. Pulse should be checked 1 hour in both, and maternal BP check every 4 hour in first stage of labor, and in second stage of labor every 1 hour. Maternal temperature check every 4 hour, and in second stage of labor also check every 4 hours. So these are the important points, and now the certain things are updated. For example, in previously partograph, there's some not a proper portion for the fetal heart rate and for the maternal point of view. So the updated WHO labor care guide, you have to quick go through that because they are recently updated, and that they have everything for maternal change of the position, a companion is very important, and for fetal heart rate they have added acceleration, deceleration, or meconium, CACPET, everything they have given in WHO labor care guide beautifully. So the other thing important point is that, and they have a specific time range given for at every centimeter. For example, if she's for 5 centimeter, so you have to wait for at least 3 hours in 6 centimeters. So they have given a time frame for the in WHO labor care guide, and worldwide now practicing that you have to the WHO labor guide is now practicing, so you all have to know very clearly about that. So in that case, but we have to follow the NICE guidelines. So in that case, they are not updated the specific time frame. So in that case, you have to choose in exam point of view. You have to remember that in first stage of labor, you have to check, you have to do per vaginal examination every 4 hourly, and in second stage of labor every 1 hourly. Now, the important point we will discuss in that the delays. And second stage of delay in first stage, because they are very important for exam point of view, and the almost the ops portion is almost majority of the MCQs and especially EMQs came from the this delays. So keep it very so you have to do it very thoroughly. So now we will discuss this. So normally, as we have discussed that we have to do PV every 4 hourly. Then what you have to do at every 4 hour, how much progress we will needed. So in that case, progress in 4 hours, 2 centimeter progress is normal. But if in 4 hours the progress is less than 2 centimeter, then we will call it as a suspected delay, as given shown in the diagram, that if it is less than 2 centimeter in 4 hours, you will call it as a suspected delay. So in suspected delay, what you have to do? In suspected delay, you will do either if the membranes are intact, you will do amniotomy, or if already the in a scenario they have given you that the spontaneous rupture of membrane occur, so in next step you have to choose PV, you have to further wait for 2 hours. You have to do per-vaginal examination after 2 hours. So this is the important point for this is the stepwise approach, and for exam point of view, you have to read the stem very carefully, that whether they have given you a suspected delay or whether it is a diagnosed delay. So in a management point of view, the management is different for both the suspected delay or diagnosed delay. In suspected delay, if amniotomy has not been done, you will do amniotomy, or if membranes are already ruptured, then you have to choose PV in 2 hours. But in this specific case, you will do intermittent auscultation, no need of continuous CTG if any high risk factor. Now, if you have to wait for 2 hours and still the and per vaginal examination, the progress is less than 1 centimeter, so we will call it as diagnosed delay. So what you have to do, or if it is more than 1 centimeter, equal to more than 1 centimeter, then same you will again reassess in 4 hours. Normally we can do as in first stage of labor, that because the progress is normal. But if it is diagnosed delay, means it is less than 1 centimeter, in nulliparous or multiparous, what you have to do, you have to start oxytocin. Consider oxytocin and full assessment before oxytocin in multiparous. So in that case, you have to assess that if the contractions, they have said consider oxytocin. Then in that specific area, they haven't said that you will offer. Because if you have to assess the patient, if the contractions are adequate and still the progress is less than 1 centimeter, then you will not consider oxytocin, because if you have started oxytocin, there will be hyperstimulation. So you have to assess the things. They have said that the contraction if the contraction is inadequate and the progress is less than 1 centimeter, you can consider oxytocin in that case. But and then what you have to do, further wait for 4 hours. And if 4 hours, if the progress is equal to more than 2 centimeter, then you have to continue a reassessment in 4 hours. But if it is less than 2 centimeter, then you have to take the decision, because still suspected delay happened, then you have to wait further for 2 hours, and there is still 1 centimeter, then you have to start on oxytocin. Remember other point, that when you have started the patient on oxytocin, you will change the auscultation, intermittent auscultation, to continuous CTG. This is also one of your SBA, that when you are starting, what are the indications for oxytocin, indication of CTG. The important indication for one point is that when you are starting a patient on oxytocin, then you will do continuous CTG. Because obviously with the oxytocin, there may be hyperstimulation, there is chance of fetal distress, reduce oxygen supply to the baby. So in that case, you will do continuous CTG. And obviously, if the still the PV is per vaginal examination less than 2 centimeter, then you will take this decision, and you will do consider cesarean section. So these are the important points for the suspected delay in first stage of labor. Exam point of view, this is very important. But another point, that at exception for example, at 8 centimeter, then after that you will reassess in 2 hours. Normally up to 7 centimeter, we will do reassessment in every 4 hours, but exception after 8 centimeter, you will do reassessment in 2 hours. So this is the important point for exam point of view. Now the other thing is for second stage of labor, so you have to remember this, that how much time we need for the second stage of labor, and when we call it as a delay. So for nulliparous with regional analgesia, we will give the patient a time frame of 3 hours, and without regional, we will give 2 hours. For multiparous, we will give 2 hours with regional and 1 hour without regional anesthesia. So these are the basically in NICE guideline, they give active pushing or active or passive. But in GTG, they have given a time frame of full 3 hours of active and passive stage. They have not differentiated that whether it is 2 hours for active and 1 hour for. They have combinedly given that for active and passive pushing, we will they include all the hours. So for exam point of view, you have to remember both, because in scenario maybe they've given you the reference of nice guidelines, but we have to follow the GTG. But you have to, for MCQ, you have combined both the passive and active stage for exam point of view. So when you were practicing MCQ, you came to know about that what you have to choose in that. So the time frame is the 3 hours for nully and 2 hours for multi for with regional, and 2 without and 1 without regional anesthesia. Now what we confirmed delay, it means that the patient is not progressing after 2 hours of active or passive pushing, or multiparas after 1 hour of active pushing. So this one is without epidural. So add 1 hour if the epidural was commenced, because in epidural we will give in nariparas 3 hours and multipara 1 hour. So after this time frame the patient is not delivered, then we will call it as a confirmed delay, and it is a prolonged second stage. So in that case what you have to do, you will take a decision whether you have to apply instrumental delivery, depend upon the station, and whether you can go for the cesarean section. So if the station is at 0 or below, and there will be no caput molding and the fetal heart rates are normal, so you will go for the vacuum delivery. But if there is, in MCQ they've given you that there is a caput molding, station is below +2 +3, but caput molding and there is a fetal distress, because you have not to apply vacuum on caput or molding, or when there is a distress, because vacuum will take more time as compared to forceps. So in fetal distress you have to choose the forceps delivery. So these are the important point you have to remember. And other thing is that if you will not give oxytocin at prolonged second stage, you will not give oxytocin you will give if within 3 hour time frame, if any time you will counting the contraction every 30 minutes, and and if you are suspecting that the contractions are a bit low, like less than 2, less than 1, then at that time frame you will start oxytocin. Take decision on that time. But if the duration, the 3 hours have gone, in that case you will not start oxytocin, because that is your decision. You will take the decision very lately. In that case you have to do a decision of whether you can apply instrumental delivery or you can go for the cesarean section, because 3 hours and gone, and you came to know about laterally that the contractions are not adequate, I have to start oxytocin. So this point will be wrong. So for MCQ point of view, you have to remember these points, that in prolonged second stage you will go directly towards instrumental delivery or cesarean section, you will not start oxytocin. So these are the important points, summary point of the intrapartum care NICE guideline. Hope you'll find the lecture good. If any queries, kindly comment on the lecture. And if you want to add something, or something like which you recommend that we want to discuss that guideline, so I will take that lecture according to that. So thank you so much.